and let us know that you're here. So Jonathan?
Here.
Thanks.
Here.
Crystal?
Here.
Excellent. Sharon? Tony?
I'm here.
Hello. I almost said good morning. I don't know where I am, but good afternoon. Michelle, I think she is missing today, but she provided some written comments we'll get to later. Shannon?
Here.
Thanks. Chandra? Elizabeth? Greg? Lon? Katina? Mandy?
I'm here.
Great. Ginny?
I'm here. Good afternoon.
Hello. Sean?
Here.
Great. Stacy?
I'm
Maddie?
here. Sorry, took me a minute
Oh,
to get
okay.
off mute.
Thank
My fault.
you.
Hi.
Maddie? Meg? Okay. I think that's everyone. Did I miss anybody? So please join me in turning to the April 23rd meeting summary in the meeting materials. And as a reminder, the recording of our last meeting is posted on our webpage. Is there any discussion of the meeting summary, or would someone like to make a motion?
Move to approve.
Motion to approve. Second.
Excellent. Perfect. All in favor, say aye.
Aye.
Hi.
Aye.
Any opposed? Excellent. The April meeting summary is approved. So now I'm going to turn it over to Rochelle for public comment.
Thank you, Judy. And it looks like the public comment period starts at 2:10. So I'll go ahead and say my spiel, but we will have to wait until 2:10. If a member of the public wishes to provide public comment, please raise your hand. When you're called upon, please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time. And to provide verbal public comment, please accept the invitation to join as a panelist so that your camera and microphone can be enabled at this time. And due to the number of speakers, verbal public comments are limited to 2 minutes per individual. The committee will listen to all public comments received during this time, but will not respond to public comments. And members of the public are also welcome to submit written comments via email at any time using the classboard and docs. So let me check to see.
You're good to start public. We just can't end it before the public comment period starts.
Thank you.
Yes. No.
Okay. Let me check to see if you have any hands. I'm not seeing anything. Okay, I don't see any hands, and it is 2:10 now, so we can close public comment.
Oh, wait till 2:11. Just out of abundance of caution, if there's anyone that's intended to join today's meeting to provide public comment, want to make sure they have that opportunity. But also seeing that there's not any commenters not wanting to take up post time.
This is where someone can tell a dad joke since it's close to Father's Day, or, sing a song, fill the time in any other way.
Okay, we can go ahead and close public comment now. It's 2:11 and there's no hands. So I'm going to turn it back over to you now, Judy.
Great. So I'm going to go through kind of fast a series of slides from the last cost board meeting in May, just to sort of refresh you on where they are. We've been doing this sort of tossing things back and forth between us, so some of this should be familiar to you. So next slide. So the cost board in May had a presentation by Dr. Kevin Grumbach to talk about primary care spend while controlling healthcare costs. There was a cost driver data presentation. The Health Alliance presented about their work and the common measure set. And then there was a presentation about market consolidation and primary care. Next. So this is a few slides from Kevin's presentation. Next. In California, they have an Office of Healthcare Affordability, and they adopted these policies in 2024 to double primary care spend to 15% over 10 years and to cap overall spending growth. Next. So he and his team have done some work about modeling the average annual growth rates and estimated spending amounts and sort of how to do that based on 3 different scenarios of kind of strictness. Next. And then looking at the 10-year spending projections for various healthcare sectors. I'll show a couple of results for primary care and hospital and ED spending to demonstrate the potential for impact of doubling primary care spend. Next. Oh, he shared that. Sorry, there are already slides on that. Next is the cost growth driver analysis. This is just an update of the data that we showed you at our last meeting. There were a couple of things that changed, and so we just have updated numbers about how overall claims spending grew by 64% over that time. Next slide. And that spending for categories corresponding to other medical increased the most. Oregon has also observed this increase, and increases in this in both of our states were driven more by price than utilization. Next slide. And then there was some talk about how breaking out some subcategories of the cost drivers might be helpful in future analyses to be able to sort of figure out where things could be changed or where pressure is being applied. Next slide. This is a couple of slides from the Health Alliance Community Checkup Report. So the community checkup is something that the Health Alliance does every year, looking at these various areas, the total cost of care, trend, utilization, quality of care, and variations of that. In the last few years, they've added area deprivation index and then adjusting total cost of care for that. Next slide. And they shared some interesting data about primary care. In their data, 27.5% of commercial employees do not attribute to a PCP, but they have claims in other areas, maybe with specialists or with ERs or hospitalizations. And then another 12% have no claims at all over the year. And for Medicaid, that number is a little higher. So 31.9% don't attribute to a PCP. And 21% of members have no claims, and that is consistent with national results because Medicaid tends to be a younger population overall. And how they defined PCP attribution was 2 or more visits with a primary care provider in the past 2 years in their data. So that was kind of interesting and work to be done. Next slide. And then they looked at this in none of this is surprising, that the impact of not having a primary care provider means that you got fewer screenings and preventive visits. So there is that. Next slide. So they left us with some solutions about making primary care foundational, investing more where the needs are greater, and thinking about purchasers buying for value and really focusing on patient safety and encouraging cultures of health and wellness at work. Next slide. And the final presentation was about healthcare consolidation and primary care. Next. And nationally, nearly half of PCPs are hospital owned. Next. And this has likely led to higher prices because hospital-owned PCP visits are about 10% more expensive than independent practices. Also more expensive for private equity-owned PCPs. You have an email from Michelle about this United Health stat. They did an independent analysis after this data came out, and they don't think this is an accurate reflection of their data. So I encourage you to read her email, and that'll be in the packet for after it's posted publicly so folks can see it. Also, higher cost settings. After physician practices are acquired by hospitals, more services are referred to hospital settings, and Medicare spending increases a fair bit. Next slide. So what other states are doing in this area are transaction review laws, cost growth benchmarks, and primary care spending targets. And in particular, Oregon has a market transaction review process with the ability to stop consolidation that looks at cost, access, and equity, and in particular, looks at the impact on primary care. Next slide. Transaction review laws that have a primary care focus can help ensure access to primary care and look at price transparency. And as of August 2024, 15 states have enacted transaction review laws. Next slide. So that is the overview of that. I'm going to move on to the provider forum. So one step that maybe not all of you know about, but in the budget, not this legislative session that just ended, but the one before, the legislature provided a proviso to establish a primary care provider forum. And I think, as you know, we have this multi-payer collaborative going on. We have a purchaser group, and we had a provider group in the past that had dropped off. And so this has helped us start that specific provider group thinking overall primary care. And I wanted to make sure I brought it to your attention because it is going to pick up. Its next meeting is in September. And so I think there is nice sort of continuing to carry the water and sort of pass things off to each other of discussion about primary care and how to keep things moving. So in the proviso, the Primary Care Forum is charged with providing input to HCA about our primary care transformation model, thinking about implementation challenges and strategies from a provider perspective, and then trying to fix those issues. Next slide. We've had a couple of meetings, including one in March that was an in-person meeting with the providers and the payers, focused around 3 areas: quality metric alignment, primary care spend, and prior authorization streamlining. And at the end of the day, there was sort of brainstorming about what to do in these areas and then voting. And so these are the top 3 ideas under each of them that that came to light. I think one of the big takeaways for me was that we need to do more about giving awareness for the work that is already being done by this committee on primary care spend, because there were questions about, are we measuring primary care spend, and what does that look like? You all have defined primary care spend for us, and I think done a very good job at that. And so we need to make sure that people know about that. And then people were interested in this transparency about how money gets to primary care, particularly in big systems, which I thought was interesting. Focus area 1, I'm going to jump back to quality metric alignment. This is also work that you guys have done, and the Performance Measurement Coordinating Committee has made a list of quality measures for primary care that we all agree on. And so there was some confusion about that, or people not knowing there was a set for this, and wanting to have overlapping infrastructure and universal measures wherever is possible. So we have more work to do to talk about that and spread it. And then focus area 3 was about prior authorization streamlining. This was really focused on some of the work that is being done. There is federal and state legislation around APIs, which is a way to transfer electronic data and make prior authorization easier. And some talk about having a unified process for sort of how to do that, and learning from a work group that has since stopped meeting that talks about a prior authorization work group for this. And folks in the room, I just noticed the recording is paused, it looks like, or maybe not.
It looks like it's still running on our end.
Okay, that's good.
Yeah, I
next
think
slide.
that may be the timer, Judy.
Okay, great. Next slide. So that is everything with that. Are there questions or comments? I know a couple of you were on the provider forum and took part in some of that. Okay, well then let's move on. Our next presentation focuses on one of the central questions this committee's been exploring all year. What does meaningful investment in primary care look like, and how can policymakers ensure those investments translate into better outcomes? So I'm delighted to welcome Dr. Russ Phillips. I've known him for a long time, since I was a junior faculty way back in the day, and his colleague, Dr. Amy Pollock, who are going to share their work. And I think this is especially relevant to our discussions because it examines some of what physician organizations and payers have learned from investing in advanced primary care services, what barriers they face, and policy approaches that appear most effective. So welcome, and I will turn it over to you now.
Hey, great. Thanks so much. Are you able to hear me okay?
Yes.
Okay, great. So I will be presenting on some research that we've been doing, which is exactly what Judy just spoke about. We'll also at the end talk about some work that I've been doing, actually, or a number of us have been doing with Kevin Grumbach, who had presented recently, and that's actually related to how we might evaluate primary care spending and the policy implications of that as well. In introducing just the other speakers, Ami was the research director for the Center for Primary Care at Harvard Medical School. As mentioned, a professor of medicine. I was director of the Center for Primary Care. Drew Ritchie has been working with us. She's a MPH student as well as a research associate. And then our collaborator who's not with us today is Uri Song, who is a health economist, a primary care physician. He actually sits on the cost board in Massachusetts, which is very parallel to your group as well. And I think, and we'll be presenting to the cost board some of our work and some of his perspectives at the meeting in the fall. Next slide. So these are our disclosures. And then next slide. Just some quick background, and I know all of you know this, but U.S. primary care is severely underfunded, with generally 3.5 to 7% or so of total medical expense being spent on primary care, despite the strong evidence that you've all been reviewing about improved outcomes with increased spending. The underinvestment itself creates workforce shortages, limited access, and worse patient outcomes. But some states, such as yours, are mandating and encouraging new spending in primary care. And some organizations are making new investments in primary care. And what we intended to do was learn from those organizations about what they were investing in and what the impact of those investments were. So with that, I'll turn it to Ami. I see Ami is here. So I guess, Ami, can you hear us? I see you're having trouble turning on your camera.
Perfect. Sorry about that. I think I was blocked, but now I can. Thank you.
Okay.
Thanks, Russ. Thank you, Judy. I'm really pleased to be here. Thank you for inviting us today. Yes, and so I'm now going to share a bit more about our study methodology and our findings, and then I'll pass it back to Russ in a few minutes. So our goal, as Russ was saying, was to learn from health system organizations and payers who have already made investments in advanced primary care, to learn about how they prioritized investments and the impact of those investments, and to share their experience in a guide that would hopefully be a useful resource to others as they look to strengthen primary care. In addition to learning from organizations about their experience, we also completed systematic reviews of the literature on the impact of advanced primary care services. You can go to the next slide, please. Our study included qualitative interviews with primary care leaders of provider organizations, practices, and payers across 5 states, including Massachusetts, California, Oklahoma, Oregon, and Rhode Island, all of which are encouraging increased primary care spending and represent geographic diversity. Within 3 states, we identified provider organizations that had increased spending in primary care using available data. And in the remaining 2 states, they lacked data on primary care spending by organization. So we selected organizations in those states through nominations from primary care leaders within the state. The sample did include pediatric and Medicaid-focused organizations. And we also included primary care practices nominated by the participating provider organizations and 6 payers across the 5 states who were nominated by state partners as supporting primary care investment. We completed key informant interviews with organization leadership, and we analyzed the data using standard qualitative analysis procedures, methods. Our rapid literature reviews relied on research published since 2010 in PubMed, and we worked with a medical librarian to select search terms. We will not present our findings from the systematic reviews today, but they did validate the experience of participating organizations, and a lot more information about that can be found in the guide. Next slide, please. Okay, so now I'll share some of our findings. The health systems we interviewed prioritized 6 advanced primary care service areas for investment. So I'm going to walk through each of those 6 service areas. 3 of them are on this slide with a summary of findings. I know this is very busy, so I'm just going to highlight a few learnings. Behavioral health integration was most often consisted of an embedded behaviorist, or less often had a collaborative care model. Barriers to behavioral health integration included included workforce shortages, concern about an inability to meet patient needs, inadequate reimbursement, and lack of community resources. The impacts that we heard of included reductions in hospital use, improved patient outcomes, and improved clinician satisfaction. Revenue was insufficient to cover costs for behavioral health integration. The quotes from respondents that we've included on this slide and the next were chosen to show reasons why organizations wanted to develop and sustain these services. So for behavioral health, one system leader shared that behavioral health has been really beneficial to both patients and providers. One of their biggest concerns for their patients was getting them access to behavioral health resources within the area. Clinical pharmacy services included chronic disease management, medication management, and sometimes management of medications dispensed by 340B pharmacies. Barriers to clinical pharmacy included inadequate reimbursement, the challenge of building trust with clinicians, and scope of practice limits. Impacts included improved control of conditions such as diabetes and hypertension, reduced hospital use, reduced burnout, and lower patient medication costs. Again, revenue was most often insufficient to cover costs. Another participant quote that emphasized positives was that we have a pharmacist who can manage a cohort of diabetic patients, check medicines, do adjustments, give them education, and we do that in partnership with the PCP. Embedded care managers worked with high-risk patients to organize their care. Centralized support often helped identify patients in need of care management. And barriers that were reported include inadequate resources to offer the help needed by patients, workflow challenges, and limited reimbursement. Impacts that we heard about included decreased hospital use, improved post-discharge follow-up, and reduced clinician burden. Again, revenue was not sufficient to cover costs. One participant said, our health navigators do the pre-visit planning and post-visit follow-up, helping patients coordinate referrals, schedule referrals, and close the referral loop. Next slide, please. The other advanced primary care investments that were prioritized are shown here. Population health teams work to close gaps in care and help to control common conditions such as diabetes and hypertension. Challenges that we heard of involve data integration, staffing, and financial support. Impacts included improved population health and reduced hospital use. Although revenue from quality incentives often drove this work, bonuses did not necessarily flow back to the practice. One health system leader said, we've done the mini-Z assessment every year since 2017. Last year, we saw a remarkable improvement. Job satisfaction was 32% higher and burnout was 13% lower in practices with the population health model in place. Addressing social determinants of health included screening for needs and helping patients obtain community-based resources. Barriers included limited community resources, creating a working referral network, lack of financial resources to assist patients directly, and the lack of reimbursement for services. Impacts that we heard of included reduced hospital use, less burnout, and improved patient outcomes. One participant said, we contract directly with community-based social service organizations, paying for staff time and reimbursing them for goods, tailored meals, housing supports, first and last month's rent to address our members' needs. And finally, e-consults offered clinicians access to specialists for help with patient care. We heard challenges associated with e-consults, including increased primary care burden, a lack of reimbursement, limited specialist availability, and workflow challenges. Impacts that we heard about included faster clinical decision-making, decreased referrals, improved patient experience, and enhanced clinical capacity. One health system leader shared, the PCP can just click cardiology e-consult, and within 24 hours, often in an hour or two, they get back a board-certified cardiology consult. It saves in-person visits with very good patient and physician satisfaction. Next slide. In our conversations with payers, they strongly agreed with investing in advanced primary care and saw those investments as essential for improving quality, equity, and cost management. But they did share a number of challenges, including concerns that investment dollars don't reach frontline primary care in complex health systems, that incentives aren't aligned across payers, that small practices have limited infrastructure to offer these services, and that workforce shortages may limit use of investment dollars. They were concerned that potential reductions in hospital use would not occur if the health system did not fully focus on achieving that reduction. And they also shared the concern that any savings or quality-based financial rewards may accrue to the organization rather than to frontline primary care and not be available for further investment in primary care services. Payers did emphasize several solutions, including greater accountability and transparency regarding funds flow, multi-payer alignment on incentives and payment, paying for infrastructure support, and global payments paired with system incentives to reduce costs. Next slide, please. Cross-cutting insights from our research indicated that no one size or service fits all, and investments need to be tailored to patient needs, staffing, and the policy environment. Secondly, we heard that hybrid care models often work best. So centralized analytics and resources paired with local delivery optimizes both efficiency and relationships. Third, we heard that workforce shortages are a critical challenge, and issues with recruitment, retention, burnout, and turnover all consistently constrain advanced primary care service delivery. We also heard that efforts to improve health equity, such as culturally tailored outreach, community health workers, and services that address social barriers to care, can reduce care gaps and drive cost savings. And finally, investment dollars must reach frontline primary care. Sustainability depends on reinvesting savings and quality incentives into the care team. Next slide. Several of our recommendations for stakeholders included in the investment guide are shown here. There is a lot more in the guide, but we wanted to highlight these. Provider organizations need to be able to offer advanced primary care services as part of primary care. And they should adopt hybrid central local models with an emphasis on having patient-facing team members within local practices and having all team members that work on advanced primary care fully integrated into the care team. Payers need to find ways to offer upfront transformation funding and adopt hybrid payment models that combine prospective payments, incentives, and fee-for-service funding with adjustments for clinical and social complexity so that practices caring for patients with greater needs have the necessary resources. And policymakers need to mandate or incentivize increased primary care spending through state or federal targets with enforceable mechanisms to ensure that funds flow directly to frontline primary care practices, with some funds designated for advanced primary care services. Funding levels should be sufficient to support the services being provided within practices. Policymakers also need to strengthen workforce pipelines, and policies should require transparent tracking and reporting of primary care spending and funds flow at the organizational level to enable benchmarking, monitor progress towards targets, and inform policy adjustments. So taken together, we see that increasing investment in primary care is necessary, but it is not sufficient. We also need to consider how to invest in primary care, recognizing that investing in advanced primary care services is necessary for improving outcomes, quality, equity, value, and clinician and staff well-being. Investments must be intentionally designed to reach the front line, to support teams, and to align with the needs of patients and communities. Thank you very much. I'll pass it back to Russ.
Okay, next slide, please. Thanks, Ami. So, what you've heard is that the organizations that are investing in primary care are often investing in advanced primary care services but find them really challenging to sustain because oftentimes the compensation or reimbursement for those services is really inadequate. So, our managers sustain them either because there's some ROI, sometimes in terms of reduced burnout and improved retention of primary care physicians, or just knowledge that they're improving patient outcomes. And of course, there's some potential financial savings as well through reduced hospitalizations and emergency room visits. We can actually provide the link to that report so that you can review it in detail if you're interested in seeing more of it. I'm now going to switch to a separate report that was actually published by the Milback Foundation. And this is the one that I mentioned that was actually led by Kevin Grumbach and a number of us. And it was really meant to provide sort of a framework for evaluating primary care investment. But what I've added is really the policy implications to make sure that, in fact, the primary care investment is being spent in a way that results in the outcomes that you're hoping for, and that where policy can influence that. There are six or several different areas here in terms of the evaluation framework. The first was that, of course, the intention is to spend more on primary care. And as you've done, the first is to define primary care investment consistently, and then you want to measure it to confirm that investment is occurring. Also to consider measuring in other areas. So if you actually anticipate that it may at some point reduce hospitalization or emergency room visits, to be looking at those effects as well. And the policy implications are really to enforce and incentivize targets. We know that setting a target without any enforcement is very challenging to meet. And I know, many states have been wrestling with that. The second issue is multi-payer alignment, which I know you're thinking about. In Massachusetts and in most states as well, finding ways to include ERISA employers is really important as well, because the state generally can't control what happens in terms of whether ERISA employers will actually increase primary care spend or not. And we can talk a little bit at least about one of the solutions that's being considered in Massachusetts, which is a common fund that is actually supported by the payers and distributed to practices directly. The second part of the framework is that whether money itself reaches frontline practices, and that's something that you've thought about as well. One of the ways to measure that is to look at practice effects, whether the revenue is actually increasing at the practice level, whether staff are being retained and hired, whether you're improving access to care and panel size, all the things that we think should happen if you have money going into primary practices. But you really need to consider a payment structure that will actually incentivize an increased panel. And this is where hybrid payment, we've heard that from the payers, but of course, many experts feel like that is an important solution as well, with a capitated payment that emphasizes increased panel size. Fund flow transparency, you've heard us talk about that already. I know that's an issue for you that you've been considering as well, but also cost and revenue reporting. And I know that you're also talking about a registry and certainly trying to get that data to the practice level, which would be great because we actually often have very little data on what services are actually costing, and to what extent they're matched by the revenue that's coming in. A third area is practices implementing advanced primary care services. You've heard about the importance of those. And in some ways, you need to think about measuring the provision of those advanced primary care services. That's also kind of data that could be collected through a registry. But those are the things that you just heard about, like behavioral health integration, care management. And again, you need to incentivize those services in a way that payment sort of covers the costs. In Massachusetts, one example is Mass Health, where they actually do have a capitated payment and pay at a higher level. And that's what we're looking to legislate in Massachusetts as well, so that practices that offer more advanced primary care services participate in higher primary care spending or revenue. And that the payment itself, sort of incentivizes, I just meant, provision of those advanced primary care services. Next slide. There's a typo here, but it's really meant to be improved. Whether this increased spending is improving the core functions of primary care, and these being continuity, comprehensiveness, first access, and coordination, and then making sure, again, that we're incentivizing those services, again, using the Mass Health example, the kinds of things that I show on the slide are actually things that Mass Health pays more for in terms of whether those services are being provided. Improving patient and primary care team experience is another evaluation framework, and that's what you can measure through quality metrics, certainly primary care experience, patient experience measures as well. And there, the implication from policy is to build in and pay for that quality measurement and improvement, again, with dollars reaching frontline practices. As you've heard from Ami, that often doesn't happen. So those resources can't be used to actually pay for services that are as part of the budget. And then to see whether that cost that can be reduced by primary care are actually reduced, and here, to consider a logic model and what costs you anticipate will be reduced over what timeline, and how those should be measured. And in some way, trying to collect those data are challenging, and so making sure that you can account for cost measurement and reporting across the entire system as part of the policy as well. And then finally, improving equity, and here assuring that the data quality are sufficient to monitor effects of investments across all relevant patient characteristics, and then being able to actually account for the measurement of spending, access, health outcomes, and quality across all relevant patient characteristics. Again, that can be challenging to do. So thinking about how you can embed that in policy so those data are being collected as well. Okay, next slide. Here, we just want to close with acknowledgements and recognize the California Healthcare Foundation, the Commonwealth Fund, who funded the work that we presented to you. Especially want to thank Catherine Phillips and Corinne Lewis, who were our project officers at the two funds, and were really important to the conduct of our work. The Primary Care Collaborative helped with sharing our results, and then also the members of the Primary Care Center Roundtable who participate in the development of the evaluation model. I won't go through all advisors, but we were fortunate to have a large number of really expert advisors working with us. And with that, thank you so much for the opportunity to present to you. And to the extent that there's time available or questions, Ami and I are happy to entertain that discussion.
Yes, we have time for questions. So, committee folks, do you have any?
John West, I have a question about early models to track accountability for practices in terms of how they're spending if they're being supported for advanced primary care. I think that's one of the challenges that I recognize is if you pay organizations more, how do you guarantee they're actually spending it on primary care? And I think from the primary care physicians I've known over the years, they're not interested in getting paid personally more, but having that money spent on support to improve patient care and then sort of allow them to have more time with patients. So are you aware of any models that are realistic and or I guess I would say not overly burdensome that can track where that money is going in organizations?
Yes, so I referenced the Mass Health model, and just to go into that in more detail, they made this change, I think, 4 or 5 years ago. And what they do is they essentially increase primary care payment by setting the floor of what the payment had been in the prior year, but then adding a capitated payment to that. And they had 3 tiers in terms of the level of capitation, and the third, and as you went up in advanced primary care services, you actually qualified for the more advanced tiers. So they actually were paying more for additional services. As just one example for behavioral health integration, they paid at the lowest level if you were simply screening, for anxiety and depression. They paid at a higher level if you had embedded social workers, and then they paid at the highest level if you were had an embedded psychiatrist and and addiction services as well. So, and they, is sort of similar across the other, care management, population health activities, e-consults. For instance, if you provided e-consults, that qualified you for the highest tier as well. And their model required attestation that these services were being provided. And they did that primarily to reduce the burden. And I know they are doing, they're doing some evaluation just to confirm those attestations are correct, but it's largely based on the attestations that are being provided by organizations.
That's helpful. Yeah, the attestation with potential audit seems to make some sense. Thank you.
Yeah. And I would say in Massachusetts, there's just legislation that passed our state Senate that is very much aligned with that model that would, cover our commercial non-ERISA practices as well. It has not yet gone through the House, so we have to see what happens, but it sort of is, it's very parallel to the Mass Health model.
Excellent. Tony?
Yeah, first, thank you for the presentation. Great information. Having looked at different states, different models, I'm curious about your perspective on voluntary versus those states that have been put in some kind of a mandate to see which you've seen is more effective.
Yeah, we're actually doing an evaluation now. Actually, Zuri Song, again, is leading that through an HRQ grant, which unfortunately is not paying out any longer, but somehow we're going to try to continue the work. But I don't have all those data, to present right now. But the reality, is that unless there's some way to enforce it, it's really challenging to, make it happen. In most states, there's not specific funding that's set aside, to accomplish this. So the intention is that organizations will find ways to rebalance spending with more going to primary care, and that is just, it's very challenging to do unless there's some, sort of requirement and monitoring of that. I know, we've heard presentations in California where there isn't enforcement, but on the other hand, there's also the cost limitation on costs, and it sounds like there would be some negotiation around being able to increase costs beyond their thresholds and not being able to do that unless you're paying more for primary care. But they recognize that's a challenge. I'd say in most states that the enforcement is relatively minimal, but the aspirations are great.
Thank you.
That is for sure where we are. Yes. Shannon?
Yes, thank you. I'm listening to this presentation and the other, very interesting. When we refer to primary care providers and things like this tiered with advanced primary care services with a high level for embedded board certified psychiatrists. I'm a nurse practitioner. I represent ARNPs United of Washington State, which across the country, ARNPs and PAs are providing huge amounts of care in FQHCs and other primary care settings. So when you in groups like yours look at this work, are you looking specifically at physician services, or are you able to separate out or incorporate those provided by other primary care providers who can provide the same types of service? Nurse practitioners, PAs who are in primary care as well?
Yeah, absolutely. I mean, it really is meant to be inclusive of, all primary care clinicians. So,
okay.
So that's certainly included.
Do you break it out? Yeah. Are you able to break it out? Like I just know in Washington State, psychiatric nurse practitioners who are able to prescribe and do therapy are more and more embedded in pediatric and other practices. So I'm just thinking it'd be nice to be able to call that contribution out and see their salaries are less, and in our state, the reimbursement's less as well.
Mm-hmm. Yeah, so I'd have to go back and look at the Mass Health requirements. It might be an embedded, clinician who is, sort of
Okay.
prescribes psychiatric medication. So it may be inclusive of both psychiatric nurse practitioner as well as a psychiatrist. It would certainly
Okay.
make sense to do that, as well. But I honestly don't know.
Don't know.
I do know,
Okay.
it's very sometimes difficult when we look at large organizations to know what nurse practitioners are doing. Within primary care practices, if they're nurse practitioners, you can assume that they're doing primary care. If they're in multi-specialty practices, which is often the
Mhm.
case, it's hard to know whether
Yep.
they're actually doing a specialty or not. It is an
Mhm.
issue in terms of data and sort of labeling, in terms of what nurse practitioners are often doing.
Yeah. Right.
But, as an example, we did a large study where we looked at the relationship between life expectancy and primary care access. And we could show that the increased density of primary care physicians improves life expectancy. And then we tried to do a second analysis looking and trying to be inclusive of nurse practitioners. And we just were unable to do it because we just didn't have data on sort of nurse practitioners and physician assistants who are actually directly involved in primary care.
Even if you looked at billing data, you couldn't tell.
Yeah,
Oh.
we couldn't. I mean, some in some
Hmm.
states they bill sort of incident to primary care to physicians. It sort of depends, and there are data under in terms of the organization.
Right.
Um,
It may have to do with reimbursement. 27 states now don't require any kind of delegation. So, okay, I'll get off this
mhm,
topic, but that's good to know. We're
yeah.
having the same trouble sorting it out. It's difficult to do, but we think there might be ways through billing data, possibly.
Mhm, mhm.
Yeah, we are definitely haven't been able to figure that out either. Sorting out where exactly, especially PAs, there's at least some ability to have advanced practice nurses be able to say, are they primary care, are they but PAs are only medical and surgical, and so that is super hard to tell what the medical ones are doing. Yeah, so it'd be great if there was more there.
Yeah, I'm sure. I think by the time we give our presentation in the fall, Zuri will have completed more of his analyses of the Rhode Island experience and probably at least one other state. And I think would be able to address this in more detail because certainly, in looking at primary care spending, so one of the things he's doing is sort of just first checking to see whether primary care spending has gone up. And that obviously it includes, all dollars being spent in primary care practices and all clinicians who are practicing primary care, which certainly includes nurse practitioners and physician assistants, but has to make some assumptions about what's going on in specialty practice and multi-specialty practices.
Yeah, we have a definition that includes the place as well as the billing codes and the provider, and I think that helps some, but it still isn't perfect. So yeah. I really appreciate, I have a question. I don't know if anyone else does, but I appreciate this information. I took some notes and some ideas, in particular to Sean's question about the attestation. But based on the work, both that you've done here, but also especially in Massachusetts, if you could help us wave a magic wand, and thinking that we're going to have to make some recommendations at our next meeting, what recommendations do you think would have the most impact that this committee could do?
Well, so funding transparency is, I think, really huge. It's like
Mhm.
having practiced primary care for a very long time. And actually, in doing this study as well, initially we were told we'd be able, we'd learn about how dollars are flowing. But when it came to actually sharing that, organizations, were not willing to share that even anonymously as part of a research study. And so we weren't able to find out exactly what was being spent on these services. In my own institution, we have money that, we know where the professional fees go because that goes to the professional organization that pays me. But for the funds that are meant to support the rest of primary care activities, we have, not only do we not know what's collected, we have no idea how it's spent. And, unless we have some ability to track that, and, it's really impossible to know whether money is really going to primary care or not. And so that transparency is, I think, really, important. I'm not sure it's going to be easy to get, and it won't happen without legislation because the payers aren't able to influence that either. You heard our comments from payers about their frustration about that. They essentially can make grants for certain activities, but they don't really know where the money's going. So transparency is really important. In Massachusetts, at least, as we've tried to move things forward, accountability has been really important as well. So exactly, it's not only transparency, but what a dollar is being spent for. And that's partly, it has driven the interest in supporting advanced primary care services, because we know that, certainly we need to pay clinicians more, we need to pay staff members more. There needs to be more money in primary care, but we can also deliver a better experience and better outcomes and more return on investment by making sure that that practices are adopting advanced primary care services. Of course, the payment has to be sufficient to support that as well. And I think we still don't know exactly what all those what's required, which is why doing a registry like you're planning in Washington and trying to collect data on the cost of services being provided and how that relates to revenue is, I think, really important too. That's probably 3 different things, but
That's okay. That's good. Thank you. Do others have any questions?
Before, Ami, did you have another question in terms of that, in terms of the single thing? Is there,
Oh, yeah.
do you have anything to add to that?
I was curious to see what you were going to say, and I was thinking in my head the tracking and transparency of funds. That was so critical. We had so many people who we were speaking with who described it as a black box. And so I think until the funds can be really tracked, it's going to be difficult to make any changes. So agree, Russ. Thank you.
Ginny?
Yeah, I'm curious, since we have your brains here to help guide us, is there anything that you wish your state had done that you've seen happen in other states, but that couldn't occur for whatever political or economic, whatever reason, that maybe we could copy?
So, I think what Mass Health has done has been, is probably the example. What we're trying to do, we still haven't moved to as far as you have in terms of requiring increased investment or creating expectation for increased investment. The legislation that is right now through the Senate but not the House would move us to 15% over 3 years, and has a number of things that we talk about, but it has there's a fair amount of opposition both from payers and from healthcare organizations, and so that's a challenge going forward. So I don't think I can sort of say that that's how, it's like it is a question of how we can really get support, to do this. Another proposal, and this is something Zuri might, talk about again with the cost board, and I know you've thought about this too, but is the Common Fund, which is something we're thinking about, or we're advocating for in Massachusetts, but that would be a fund into which payers are essentially putting their primary care payments, so that then they all go through a state fund so they can actually include ERISA practice, ERISA funds as well, because that's allowable through ERISA rules. And it deals with, in Massachusetts, we have a huge market power issue where some organizations are paid up more than others for primary care based on what their overall contracts are. which creates, huge inequities in well that can be sorted out. And it also addresses the multi-payer issue in that all primary care across the state would be paid through the common fund. So that's also, I think an exciting model, but it's not something that I can say it's been operationalized. It actually is in legislation that isn't being considered by the House. That's the alternative to the Senate legislation that was already passed, which does not include the common fund, but does include the goals that I just mentioned.
It's fascinating. Thank you.
I can actually supply links to those different papers and things like that. There's one about the common fund that came out in JAMA recently. And there's also a link to the paper that I mentioned that was published in the Milback Foundation. So I can share that with you as well.
Excellent. That would be great. Well, thank you so much, Ami and Russ. I really appreciated this. I think committee members did as well. I know it is evening time where you are at, so thanks for coming to join us. I'm not sure if our next is Renee here yet.
Yeah, she's here in the room with us.
Oh, perfect. Okay. So I think a very nice theme that was in Russ and Ami's presentation is about workforce, and that primary care investment alone isn't enough if there's not the workforce needed and the whole team of primary care. And so our next presentation focuses on the workforce side of the equation. We're joined by Renee Fullerton from the Workforce Training and Education Coordinating Board. And we have heard throughout the year that workforce shortages are one of the most significant challenges facing primary care in Washington State. So today's presentation will help us understand current workforce trends, where challenges are emerging, and what policy options might exist to strengthen the primary care pipeline. So welcome, Renee, and I will pass it over to you.
Thank you. I'm glad to be with everyone today. So as Judy was kind enough to say, I'm Renee Fullerton. I'm with the Workforce Board and also have the pleasure of serving as staff to the Health Workforce Council. Next slide, please. So how primary care is defined depends a lot on the context, but for my remarks today, I'm mostly focusing on physicians here within Washington. Nurse practitioners and physician assistants, as we've heard, also make significant contributions to our primary care workforce here within the state because of our expansive scope of practice. But I always like to include many other professions that make up the team that goes into providing effective primary care within the state. And to acknowledge the fact that we have long-standing workforce challenges within many of these roles. Just have a 20-minute conversation today, and so we'll be restricting it mainly to issues within the physician workforce. Next slide. So within physician specialties, family care medicine is the one most connected traditionally to primary care practice. That's not to say that internal medicine and pediatrics don't also produce graduates that go on to serve primary care, but that is a much lower contribution because of the tendency for subspecialization within pediatrics and internal medicine. If you go to the research, it's well understood that residency location is fairly highly correlated with practice location following graduation, typically within 100 miles. And so growing residency programs and family medicine residency programs specifically has been a key workforce strategy over the past 10 to 15 years in order to increase our supply of what we hope will be our eventual primary care physicians. And we have seen that significant investment here within Washington State since about 2014, 2015. But as you'll see a little later in this presentation, unfortunately, we are facing some new challenges to our training capacity. And another challenge that we'll be walking through is that while lots have increased, the volume of medical students, at least US senior DO and MD students interested in primary care, has not seen a commensurate increase. Next slide, please. So the last time I had the privilege of presenting to you, I think back in 2024, I showed a version of this chart as well, which is showing the dark line on the top is the total number of family medicine physicians that have been offered through the national residency matching process. The match, if you're not familiar, is a nationwide process whereby those who are interested to continuing on into a residency program go through an interview and application process with all of the available residency programs, and then are matched by an algorithm in a sort of a high stakes process that takes place every week in March. As you can see, while the blue line continues to rise, the number of filled positions has remained fairly flat over recent years. Now, this is not representative of how many of those positions ultimately get filled, because there is a supplementary process that takes place after the match called the Supplemental Offer or Acceptance Program, also known as the SOAP. So while 899 family medicine physicians were unfilled at the beginning of match week this year in 2026, ultimately, I believe all but 54 were filled by candidates during sort of a high intensity, high pressure, rapid interview process that happens during match week. Match rate overall for family medicine has continued to decline. This year, it was 83% of positions in family medicine that were filled at the start of match rate. And the trend that I noted last time with U.S. medical seniors, which is the light blue line, sort of in the middle of the graph, they continue to remain fairly flat. The osteopathic medical seniors, fairly flat, even to a slight decline, which is a change from what I reported in 2024 when they were still rising. And we are seeing an increase in non-U.S. citizen international medical graduates coming into these positions. National Residency Matching Program has very much paid attention to these trends within family medicine residency match. And this spring, they announced they're convening a nationwide commission to look into the factors that are contributing to this not ideal trend within the family medicine residency match. And I hope we'll be making recommendations. I'm not quite sure what the timeline will be for those. Next slide, please. So as I mentioned, those who enter the match each year, the primary amount are U.S. MD students and osteopathic medical students, those who have completed DO or MD medical school, and then U.S. citizen and non-U.S. citizen international medical graduates. So this trend around interest in family medicine and sort of it remaining fairly flat to even a slight decline also shows up when we look at our medical student output here within Washington State. This is data shared from the University of Washington Family Medicine Residency Network. We are producing more percentage of our seniors going into family medicine than what is nationally done. However, it is a lower percentage than one might hope if you wanted to be treating a lot of family medicine physicians. Next slide. Interestingly, osteopathic medical schools, they traditionally have matched a greater percentage of students to family medicine, although National Residency Matching Program has noted this has been decline in recent years. Our state does have an osteopathic medical school, Pacific Northwest University of Health Sciences in Yakima, which I believe graduated its first class in the early 2010s. And they are consistently matching about 1/3 of their students into family medicine, far exceeding what we are seeing on the national trend side of things. Next slide. So separate from the issue of student interest and matching into family medicine, we are also seeing a changing trend in Washington's capacity to graduate family medicine physicians. As I mentioned earlier, beginning around 2014, 2015, the state sought to increase the number of positions that we had available. Overall, Washington is an under-residented state because many residency programs were established a long time ago and they are weighted towards the eastern part of the United States of America. So we've always been kind of fighting from the back so far as our production of physicians overall. And so the state has seen that, and as part of the drive to also create the new medical school, has made significant investments in growing programs. We had a really nice trend line going with increases in our total slots available between 2014 and 2023. However, as the chart pretty clearly shows, with data from the residency network, we are seeing declines in our actual capacity to train, which is very concerning. The data point for 2027 you see with the asterisks there is a projection or best estimate based on what we have heard from planned reductions at the Providence Swedish Family Medicine residency programs up in the Seattle area. So this is not good news insofar as our ability to train the physicians that are most likely to stay and work here with Washington State. Next slide, please. So moving on to internal medicine, also make up part of primary care workers. It is notable that there does seem to be an increasing trend since 2018 in internal medicine residents going on to subspecialization, say in cardiology or other programs that require fellowship training and typically indicating they will not be providing primary care services. The internal medicine residency programs also are ones that typically take in a larger number of international medical graduates. International medical graduates have a higher likelihood overall of working in rural or underserved practice environments because if they come in, particularly on a visa, there are service obligations that can be attached to those visa programs. This year in the match rate for non-US international medical graduates who needed visa sponsorship was at a 5-year low. That wasn't necessarily because there were fewer people applying to come in. We think, just as a hypothesis, that we saw fewer programs taking those candidates because of concern about processing of visa paperwork, because you need to be able to start timely on July 1 when you were coming into a residency program. So if visa timelines become uncertain, that becomes a lot of risk for a residency program to take on. Next slide, please. And then pediatric residency programs remain popular, although their fill rate has seen some of that same decline overall versus what we traditionally had seen. Traditionally, pediatric residency programs were highly competitive here, and so you can see it's opened up a little bit where they're not filling immediately. But at 94%, it is higher than what family medicine is seeing at 83%. AAP reports that about half of pediatric residents will go on to subspecialty training, and then included numbers on all these slides to give you a sense of our overall training capacity. Next slide. So the good point was made in previous discussion that nurse practitioners are good at providing a strong contribution to primary care supply, both here within Washington State and nationally. This is a snapshot from the licensing dashboard that Board of Nursing maintains. This is filtered to just show ARNP licenses. It does not include nurse midwives or certified nurse anesthetists. And but then from there, that only tells you total number of active licensees. OFM has done research the last couple of years trying to further hone down that point of how many of our nurse practitioners are providing primary care. It is a challenging one to try to get with any sort of certainty. Wei Yan's work used insurance networks to look for, of all of the licensed ARNPs, which of them were actually active within insurance networks, using that as a proxy for providing care in the state. And then of that subset, he found about 1/3 were providing primary care. And if you're further interested in methodology, there's a link provided chart there. Next slide. Physician assistant supply has also steadily risen, although not quite at the rate of nurse practitioner supply. OFM found that a higher percentage of our licensed PAs were active in insurance networks here in Washington, but a smaller percentage of those were providing primary care. That may change over time. There were supervision differences, and still are, between nurse practitioners and physician assistants that employers reported disincentivizing hiring PAs to perform primary care because of supervision that was in place. However, there were law changes made in 2024 that simplified that supervision expectation. And so it'd be something to watch to see if we see increased uptake of physician assistants within primary care and if we see any switching there. Okay, next slide, please. Following what was a bit of a quantitative data dive, I thought it might be helpful to provide context from Washington employers, and this is going to be qualitative data that we collect through Washington's Health Workforce Sentinel Network. The Sentinel Network is a partnership between the Health Workforce Council and the University of Washington Center for Health Workforce Studies. We've operated it since 2016, And it is outreach to employers with a set of consistent questions about their experiences with exceptionally long vacancies, turnover, and retention within a variety of different roles. I know these matrices are hard to interpret on a small screen. The main takeaway here is that physician is labeled with the orange rectangles in these boxes, and they are showing up as a number 1 or number 2 physician with exceptionally long vacancies. For these two employer types are rural health clinics and community health centers, both of which are primary care providing entities. Next one, please. So we set a specific set of questions this spring. Data collection was from April to early May of this year. So University of Washington is still in the process of writing up full briefs, but was kind enough to give me a preview, and I'll be able to send to the board write-ups once they are complete. We had 45 organizations. We had a screener question for our larger subset of organizations. We asked a screener question on whether they employed physician, ARNP, or PA to provide primary care services. We had 45 organizations, so indicate that they did that. And then we asked about the mix of those professions. As you can see, nurse practitioners, family medicine physicians, and physician assistants were the most common employed by the particular respondents for this survey, and then decreasing numbers of internal medicine physicians and pediatric physicians. Slide, please. Within our questions, we asked about the ability to recruit and retain by clinician type. We did find a clear difference from employer reports, with recruitment being much harder in their view than retention, and then recruiting physicians being harder than recruiting nurse practitioners and physician assistants. And then retention was a bit easier and a bit of a mixed picture, with PAs and nurse practitioners, small amount harder to retain than medicine physicians. But I always have to caveat it when we do quantitative numbers with what is qualitative data. So take this with a bit of a grain. This is from just the employers who responded to us. We always find the richness of the data from the Sentinel Network comes from the comments, the open report fields, where we get more of a sense of the why and what employers are seeing. So we'll go into that on the next slide. So when asked about recruitment, when looking through all the different themes, there was a consistent one that physicians tended to be more challenging to recruit than advanced practice providers. And I put a few illustrative moments there. I won't belabor the point by reading them out to you. But there was this first comment. They're not alone in commenting. There is a larger supply in their experience of nurse practitioners in particular. Just because they think of sort of more training programs, more student placement pipelines, and sort of a larger volume of candidates out there. And then the second comment I thought was an interesting example of substitution, where they had a pediatrician leave their practice and were ultimately not able to fill with a pediatrician, and so changed up who they're applying. This is not uncommon. We have other reports of substitution between provider types depending on who they are able to recruit in their candidate pool. Next slide, please. But I also want to make the point that recruitment isn't universally an issue. Some employers, particularly if they're able to offer a practice environment that is more desirable, don't report great challenge. In particular, I found the comment from that tribal clinic particularly telling, that many physicians are looking to get out of corporate healthcare. Tribal health clinic offers physicians longer appointment times and more personal care of patients, and their clinic frequently has physicians requesting physicians with them. So giving us a sense of what the workforce is interested in doing, and maybe moving towards locations where they can practice the kind of medicine that feels personally fulfilling to them. A bit of editorial opinion there. Next slide. So on retention themes this go around, employers report a whole range of reasons for departure. I didn't include them here, but there are always personal reasons, moving out of state for family, sort of a variety of non-related to the practice of medicine reasons for an individual to leave. But there is a common theme around burnout, and sort of burnout as being expressed by things are hard and getting harder. particularly when they bring on new graduates and it's a more challenging practice environment. Potentially, this first commenter is from Federally Qualified Health Center. If they're coming first out of school, those are the ones where they have the greatest retention challenge because it's that first sort of intro to medicine. Whereas if someone who is coming from another job and has more experience, they probably have a little bit more discernment about what the role is in front of them and are more likely to be retained. All right, next slide. And then going on to that earlier comment I made about employers reporting that the work becoming more challenging as a reason for resignations. I should have bolded the words in here to make that longer quote at the end a little more easier to parse. Sort of the second part of it, which is the report of the patients are getting sicker. There's increased need to prove medical necessity, limited access to specialty care, and administrative burden increasing. Sort of all of that is accelerating what we're seeing in departures from primary care and what I'm guessing if they're practicing clinicians on this call may be experiencing as well. Next slide. So in coming to speak with you today, it was requested that we put forward potential policy actions to help address what we were seeing in the health workforce. I reached out to colleagues at the University of Washington, WSU, PWU, and Family Medicine Residency Network, because of course I am myself, I'm not a physician. I just talk about them a lot. And we had fairly broad agreement, or just 100% agreement across our group, that many of the workforce challenges are a result of payment system challenges. And my expertise does not lie in that particular area. We had some good earlier discussion from the presenters about more of the payment system side of things. But absent impactful payment system change, we think other actions have a more limited impact on ultimate retention within primary. That said, in the spirit of being helpful, we did put forward some suggestions for areas to look at, particularly to address some new challenges ahead in the light of HR1 and how it's going to constrain student loan borrowing, which is going to be highly impactful across the professions of physicians, nurse practitioners, and physician assistants. So for those who are not familiar, HR1 limits federal student loan borrowing. Previous to this, for about 20 years, students in graduate programs have been able to borrow up to the full cost of attendance. It's inclusive of both tuition and the ability to live, pay your rent, because for most graduate training, you are not able to work during that particular time, and you may not have family resources available to support you, particularly if you're a student from a first generation background or more limited needs generally. So one policy idea that is running in other states but does not exist currently here in Washington State is compressed medical school cohorts. This is where medical school is compressed into 3 years and then saving 1 year of tuition and borrowing costs. And then it is paired with a primary care residency. So the student does not go through the 4th year, which a lot of time is spent going to those interviews and going through the match process for this. This, just to be very frank, is helpful on the borrowing cost side. This may not actually net us more primary care physicians because this is going to support ones who are already very sure about their decision to go into primary care. They're pre-committing to this pathway by taking on this approach because they would not be going through the match. But borrowing is going to be a challenge moving forward. So it's something to look at, and there are very successful models operating in other states. Another area to consider is Washington's student loan program. I have a link to the RCW there. This was created just a few years ago in 2023. Initial work was done, but it was initially capitalized at $150 million. All of that was swept in 2025 before the program was actually stood up. But this does exist as a policy mechanism in the state and could operate as last mile funding to help support students, particularly MD&D students when they reach the new $50,000 annual cap. And then ARMPs and PAs actually have a much lower cap of about $20,000 per year, which is going to be very challenging for those positions as well. Next slide. 2 other things to consider. There has been a lot of policy work in Washington State over the past 8 years on better integrating international medical graduates into our healthcare system. We have a large pool of internationally trained physicians who came and ended up in Washington State, not because they came residency program into practice medicine, but because they are generally immigrants or refugees coming here, and their pathway back into their professional practice is very difficult. Medical Commission has been partnering with international medical graduates to create pathways into clinical practice for the past several years. A clinical experience license has been operating for international medical graduates who work for sponsoring employers. This has actually seen a very large uptick by companies that provide primary care services to nursing home residents, have been utilizing the international medical graduate market through its clinical experience licenses. Senate Bill 5185 passed in 2026 and creates a pilot program to look at assessing IMG competency and to allow for a, what I'm putting in air quotes, you can't quite see me, primary care physician license, which is a new concept. Physician licenses have been physician licenses for a long time in Washington State. The Medical Commission is charged with creating a set of rules that creates a primary care physician license. And then the idea here is that they would practice under supervision with their clinical experience license for a period of time, go through an assessment process for safe practice, and then if all of that works, move forward into a primary care physician license. This is all just getting started. It'll take a bit to do the rulemaking, figure out what the assessment looks like, and it is just a pilot. However, it's very intriguing to look at this effort, and if we see good outcomes from it, determine if it should be continued past the pilot. And then finally, what I showed earlier with the concerning decline in family medicine training is something that merits attention, in my opinion. We have had this strategy nationally to incentivize hospitals to keep programs operating. There's large amounts of public dollars that go into graduate medical education. We're starting to see a pullback where hospitals are no longer wanting to participate or are shifting from family medicine to other residency program types, which may have better physical outcomes for them. And this one, I wish I had a fix it for you. I don't, but I'm very concerned about it on the workforce side of things, the diminished capacity to train. So I think it's one that just merits further attention, how we get to that particular challenge. So with that, I am happy to answer questions. Hopefully I stuck somewhat close to time. And also acknowledge there are many important aspects of the workforce I was not able to squeeze in 20 minutes as well, and lots of other conversations if you want to catch me about MAs, about nurses, about all of it. We need everyone to take away.
Thanks, Renee. We have some time for questions. Do people have any? Crystal?
Yeah, thanks very much for that presentation. Very informative. Thinking about your last bullet and your comment that that's one you don't have a magic wand for, which is unfortunate. I'm with an FQHC, and a lot of our FQHCs rely on that pipeline for our physicians. So whatever we could do to incentivize those, we know there's some of the prov locally are closing and reducing their amount of graduates, which is going to have a big impact. So hopefully there's a magic wand there. And then another, yeah.
I was going to say yes.
Thing
Go ahead.
Yeah, no, please.
I say yes, the implications for the FQHCs are incredible because a lot of the programs that have been affected are teaching health centers. Which are training physicians most closely to where we would like them to work. That's such a well-researched strategy generally. You want to train somebody as close to the environment you ultimately want them to work as possible. And for everyone's context, one of the closures is Community Health Center of Tacoma. And the challenge with the teaching health center is that you have to have a partnering hospital And it wasn't that the teaching health center had an issue, it was the partnering hospital decided to no longer support the program moving forward. But
Yep, and a concerning trend potentially into the future. Yeah, thank you for those details. One other thing I wanted to, I don't know if this is occurring with others, but just thinking of workforce generally, we've seen 14% of our workforce non-working, largely related to FMLA, generous FMLA in the state. And that's starting to have a big impact even on our provider base as well. So just a trend that we're seeing, I wanted to highlight as well. But thank you for your presentation.
yeah, we noticed that a lot in comments this year. Paid family medical leave does come up when the employer reports fairly consistently over time. It showed up against more strongly this year, I think, because there were some changes made to the paid family medical leave policy this year. And that's a tough one because we both want to support our workers in being able to do what they need, but it is a real challenge for provider or employer capacity. And last time I looked, healthcare workers do make disproportionate use of paid family medical leave, not meaning it's inappropriate, but just that they're more likely to use it than other sectors of the workforce, probably because they're more aware of it.
I have a probably silly question, Renee, but from a workforce perspective, just kind of looking at the trends and the data that you were showing, it appears that physician assistants or maybe there was that the credential type that you showed other than nurse practitioners and physician assistants, let's just say, and that we saw a pretty sharp increase in the supply for both of those. Meanwhile, observing that MDs, that trend is going down, at least those that are interested. Speaking of supply, that are interested in primary care. From a workforce perspective, why are we concerned about the supply of MDs that are interested in entering primary care when we see such a sharp increase in the amount of nurse practitioners and physician assistants that are seemingly entering the primary care space? Why isn't the number of physician assistants and nurse practitioners that have increased negating that decrease of primary care MDs?
That is a complicated question.
Okay. Sorry, I made it. I couldn't even get it out.
Well, it's not that it's. There are differences between what professions can do, so depending on the context. So, example, the employer quote I used about the pediatrician. There's additional context from that employer that the decision to substitute with a nurse practitioner, and they could no longer cover some of the pediatric call at the hospital because it was a rural community. And so not everywhere does that and has the clinician state call, but that's more common. And so then they had to ask the hospital to seek a physician to provide that coverage, which then meant they created these competing pediatric service. You get sort of weird shifting depending on, and then I can send you some research separately too, because it's kind of an in-depth topic to get into in regards to cost and what you, just how different professions impact the cost of care.
Yeah, it's just, you would think from a workforce, strictly workforce, I understand that there's different, privileges that each credential type has, but from a workforce perspective, it would be cheaper to have the physician assistant and or nurse practitioner than the primary care doc in some cases.
Depends on, you're asking me a sensitive question. In a mixed room.
Oh, sorry.
No, I don't mean it that way. I just mean it like the politics around healthcare professions are real. But the part of the challenge is you're thinking of it so far as the cost being the salary of the individual, but you also have cost from the system so far as how much of a patient's care that particular clinician is able to handle themselves versus referring on to specialty care.
Right.
So that's primary care physicians, at least in my research that I've seen, tend to do a little less referral out. And so you have sort of costs accrue in different ways across the system.
Thank you. That's
Well, thank you, Renee. That was super interesting. I'll also note that Medicaid bakes into our hospital rates some graduate medical education funds. So there's potentially a lever there as well for us to think about. But I think you have nicely teed up our last part of the meeting where we have some discussion. So we spent the last two meetings talking about various problems we're facing in primary care, the workforce challenges, federal impacts, market consolidation, financing, and have heard a couple of different strategies for approaching some of these. And so as we approach the August meeting, I want to sort of summarize some of that. Next slide. So this is going to be the process that we undertake to get to some recommendations, and how these recommendations will be used is that we will make and vote on recommendations in our next meeting, and those go to the cost board, who will vote on recommendations, and those go into a legislative report for the legislature to consider some of these actions. So we will review a summary of some feedback and start talking and brainstorming about some of these ideas. I encourage you, if you have other ideas, to send them on to us in the meantime. And then at our next meeting, we'll discuss and vote these individual policy modifications and vote on final language, and then it will go to the cost board. Next slide. So the topics that we've reviewed this year are increasing primary care expenditures, workforce development, and healthcare transaction oversight. So next slide. We have a very pretty slide that has super tiny script, but has sort of our key takeaways in those areas. And I'm not going to go over each of those because I'm hoping that you looked at this ahead. Next slide. So the team started to think about what could be some recommendations that we would vote on. So these are some straw people proposals, but what I'm really interested in getting at and having some discussion is what things do you think, are these the right things to recommend and vote on? What other things might you want to add to the list? So for primary care spending, putting in a requirement that carriers and large provider organizations increase primary care spending by 1% a year until we get to our 12% goal. For the healthcare transaction oversight, to endorse the cost board recommendation that the state pursue a healthcare transaction review program. And I'm guessing put in some, as part of that would be to look at the impact on primary care. And then there's a couple of workforce development ones here about medical schools increasing primary care. Our great presentation by Renee, I sort of liked the idea that she had of how might you have a compressed medical school and then primary care residency as a part of that. And two is to encourage the legislature to look at the loss of the family medicine residency slots that are tied to public dollars. That comment that I mentioned, that we have graduate medical education baked into our hospital rates. And so maybe thinking about how we could use some of that purchasing power in a different way. So I'll stop there. Do people have other ideas that they'd like us to talk about? Do
Judy, I
you
know
like
that
these
this,
ideas? Go, Sean.
I know that this group has been working a lot on these topics. I have to say I am a little intrigued by the Massachusetts idea of a primary care fund that is. I feel like the carriers probably would like to do the 1% increase, but I think that they're challenged in figuring out how to do that. Honestly, so not that it's a bad idea, but anyway. I think that concept of having a primary care fund, and then having some real teeth in terms of not only attestation, but some type of more clarity and transparency about making sure the funding is getting to the right place sounds intriguing to me. So,
Yeah, I like both of those. I especially like the attestation part to like, I think that's a key problem, that transparency of can you follow the money or not? So
And
great.
Sean, apologies, Judy, for jumping in, but at the July 22nd Healthcare Cost Transparency Board meeting, we're having some individuals from the Colorado Health Department, Insurance Department come, and they had an initiative several years back to require carriers to increase primary care spending ratio by X amount of percentage points. And they were successful in that, and they'll be highlighting that at the July 22nd cost board meeting. So just as a case study, if you will.
great, thank you.
Yeah, Shannon.
Yes, thank you. I just want to throw out an idea that hasn't been discussed, but it's the concept of some sort of funding or pilot for postgraduate training for nurse practitioners and PAs in primary care. There are currently 600 such programs across the country. There's essentially no federal funding. We have 35 in Washington State, including at federally qualified healthcare centers. We started one of the first hospital-based ones at Children's Hospital. I wish we had more data, but we do know that employers are funding these programs because it is a way to have a rigorous first year in practice with way less turnover and improved retention. And at Children's, we were able to show that even 5 and 6 years later, we had much better productivity and ability to care for patients. And in the FQHCs, these programs include management of conditions that I think there was an implication that nurse practitioners and PAs might refer more cases out. But when you have better training and a solid foundation for starting in that first year, it really helps. And so that's something I'd like to, I don't know how to bring it up, but I have lots of information about this and I'm on the board that accredits these programs. So still largely unknown, but it's a really wonderful initiative that's happening across the country. Again, employer funded because there's no federal funding.
Oh, interesting. Yeah, that's great. Tony?
There we go. Boy, so many great ideas here. And, one other idea that's being bounced around that I thought we might want to at least incorporate in our thought process, and Judy, you might be the best to talk about this, is this idea about universal primary care. I know our Office of Insurance Commissioner here in the state is gaining some steam. At least that's my impression in that direction, and it might influence how we might choose to invest in primary care. Anything relevant to the discussion there?
Yeah, I think that's a good idea, and I think it's very similar to what Massachusetts is talking about with that primary care fund, and how to pay for primary care, have it payers pay into a central area, and then that central area pays primary care. So yes, I think that is being talked about in a number of places, and would be interesting to pursue for sure here. Jonathan?
I'm going to piggyback on Tony, also related to the primary care fund or other solutions that I'm not quite aware of, but just my main comment is about framing that I think isn't quite captured here yet. of the potential Medicaid churn and loss of insurance coverage anticipated in 2027 and afterwards once HR 1 takes more of effect. And so I think maintaining access to primary care and creative mechanisms for funding access to primary care for people who might lose that insurance, that Medicaid insurance coverage. Perhaps the Primary Care Common Fund, funded by 1% increases from other payers, can help supplement. I would imagine these patients will end up getting lots of uncompensated care at FQHCs. Just thinking about creative mechanisms to plug that gap.
Great, thank you. Next slide. I feel like we're getting into it, but next slide after this. I think there were some discussion questions that we could talk about like who's responsible for the 1% annual increase, what workforce strategies could we address, and what are some short-term policy solutions and some longer-term ones. I think that short and long-term one especially is, I think, something maybe we should think about when we're making our recommendations. So, yes. Any other sort of considerations or thoughts based on that? Crystal?
Yeah, thanks. One thing we've heard a number of times when folks have presented from other states is making sure if there's a 1% increase, I agree, who's going to be responsible for that, but then also making sure it actually gets to the primary care systems, right? I think we've heard some cautions even today around that. So being pretty specific in here might be called for when we make our recommendation.
Yeah, I think that's a good note and sort of goes back to that attestation process that Russ was talking about. I'm interested in sort of maybe fleshing that out a little bit more. What do others think?
Comment also about framing. If memory serves, the Healthcare Cost Transparency Board, one of their charges is to focus on overall healthcare cost growth rates. Is that right? And sort of setting a target for annualized cost growth. I think Kevin Grumbach's presentation, not about the Common Fund, but about the California example of what expenditure growth would look like to double primary care in different cost growth rates for all of healthcare expenditures in California, what that would look for other categories of spend. I think that's an opportunity for us to do some sort of similar framing of if the Healthcare Cost Transparency Board is recommending, let's say, 4% annualized cost growth for overall health expenditures, and we did a 1% increase in primary care year over year, illustrate what cost growth would look like in other sectors. And I think most likely it would be costs still grow in those other elements, other healthcare sectors, but grow at slower rates rather than, oh, we're reducing your overall pay, but rather it's just growing at a slower rate. And I think some sort of analysis similar to that, based rooted in whatever the cost board is recommending for total cost care growth, could be a helpful way of framing the 1% annual increase.
Yeah, that's a great point. And especially the last cost board, Kevin Grumbach's modeling was all about that was about the effect of increasing primary care investment and workforce that helps slow overall spending growth. So yeah, so that is great. Okay, well, I want to thank our presenters today. I think we had some great discussions and some really good information that I think is nicely coming together for these recommendations. We are going to share our discussion with Cost Board at their next meeting, May 28th, and I invite you to come to that if you want, especially the part where Colorado is going to come present, because I think they'll share some interesting information. We're going to meet again on August 20th to continue finalizing our recommendations to the Cost Board. I'll also note that that meeting goes an extra half hour so that we have enough time to get to the place we need to be and vote on those recommendations. And the recording and summary of this meeting is going to be posted shortly on our website. So thank you all very much. And if you have other ideas in the meantime of topics or ideas you'd like to nominate for a recommendation, please send them to us before the next meeting so that we can organize those and sort of tee them up for conversation. So thank you and have a great afternoon.
Thank you.
Thank you.